dysplasia would I do differently?
Hyperlaxity and EDS, what do I do differently? So a lot of our patients may look like athletes like these guys. This is a very different type of arthroscopy than these guys. And this isn't entirely across gender lines, but it is a lot across gender lines. So for the most part, when we're talking about lax hips, we're mostly talking about women who have high Badens, who have hyperlaxity in general, with or without a diagnosis of EDS. So the hip ideally is a highly constrained joint with excellent bony coverage. It has a strong ligamentous complex, and of course has the labrum, which increases the volume and joint congruency and provides negative pressure, and all of these things contribute to stability in an ideal world. Here's some things that can contribute to instability, or if we don't like that term, to eccentric loading of the joint. So there's inherent and there's acquired and there's osseous and there's soft tissue. This matrix that we made was interestingly from an article in JOS about the ligamentum teres. But obviously the ligamentum teres is one of many things that are stabilizers of the hip joint. So again, really different kinds of athletes here, and it's important to understand this kind of athlete for what they are. Some of the things that can contribute to their instability may include increased femoral anaversion, acetabular undercoverage, excessive range of motion from the activities that they do, so supraphysiologic activities, ligamentous laxity, labral damage, and ligamentum teres. And you'll notice that the two articles that I've cited here across the bottom that we did, both on sex-based differences in clinical presentation, and then in the next one, the differences in patterns of pathology between females and males. And they really are different in terms of the patterns. There's obviously some overlap between them, but again, a very different kind of athlete than a football player. So in this study, we looked at female athletes and found they actually presented with lower PRO scores preoperatively, but had similar improvements in all recorded PROs and returned to sport at a very high rate, 97% continued sport. But they're being treated differently. Right? We're treating the lax athletes with capsular plications and with labral restoration in a more robust way. So back to these principles of treatment of stability, we basically want to augment or preserve every static stabilizer. So, of course, we start with rehab, which really focuses on the dynamic stabilizers. And then in the surgery, we avoid acetabular over resection. We recreate the labral seal. We do a capsular plication with an inferior shift, reconstruct the deficient stabilizers, i.e. the labrum, maybe the capsule, maybe the ligamentum teres. And if there's bony deficiency, then we do a PAO with the scope, as has been talked about here extensively. So here are the stabilizers I'm going to focus on: the labrum, the capsule, the ligamentum teres, and the bone itself. So for the scope of this talk, we'll focus on these four. So for the labrum, firstly, this was an algorithm that we presented an infographic in Journal of Arthroscopy. To dumb this down, if the labrum's repairable, we repair it. If it's not repairable, then we repair the segment if it's only a segment, or we repair the whole, or reconstruct, I should say, the segment if it's only segmental, or reconstruct the entire circumference if it's a circumferential disease. When to take this leap? In the primary situation, this is primarily for insufficient labral tissue, segmental loss, a calcified labrum, or severe labral intrasubstance damage. I think the picture on the left here, most of us would look at that and feel that is not a repairable labrum. The picture in the top right, that is about a 2 millimeter strip of labrum, and you can repair it, but I think most of us would feel that it wouldn't be very satisfying. In the revision situation, we're reconstructing the majority. If they've had a failed debridement or a failed previous repair, reconstruction plays a really big role. So the technique shouldn't be the cause of the indications, but the evolution of the technique has actually affected the indications, because as the procedure using the knotless pull-through technique has become easier, more reproducible, and quicker, it lowers the bar, it lowers the threshold to do the procedure. When you think it's going to be an unpredictable procedure, you have a very high bar to do it. If you think it's a very predictable procedure and you know how it's going to come out and you know it's going to turn out well, the bar goes down. So you'll do it comfortably for more diseased situations. So back to sex-based differences. This is with labral reconstruction. Again, high return to sport rate in both males and females, treated differently in terms of the capsule, possibly in terms of the bony morphology as well, but with those different treatments, we can achieve equivalent outcomes. Restoring stability, next one is the capsule. That picture is a capsular reconstruction with a dermal allograft. Fortunately, we don't have to do that very often because usually, even in the revision situation, we can find capsule with which to work. So I talked earlier about the technique that we first published in 2013 for capsular plication with an inferior shift, taking advantage of the standard capsulotomy. Here you can see the sutures are all placed before we tie them. So we usually place anywhere between 4 and 6 sutures if we're doing capsular plication. And then we'll tie them from medial to lateral. And this was the 10-year outcomes. And again, a high survivorship. Shane has shown similarly high survivorship. And so it seems we're able to achieve some pretty darn favorable outcomes even over the long haul if we identify and address all of the factors that are leading to their instability. Here we looked at high-level athletes and compared them in terms of return to sport. And with plication, they were able to achieve outcomes that were on par with patients who had normal acetabular coverage. So basically, we're making it as if they didn't have acetabular undercoverage at all. The ligamentum teres is next up. So an intact ligamentum teres predicts a superior prognosis of arthroscopy in patients with borderline dysplasia. Corollary, ligamentum teres that is not intact predicts a less good prognosis. So it seems that the ligamentum teres probably tears because of instability, but once it is torn, the instability itself may get worse. So maybe the ligamentum teres in a normal hip shouldn't be a stabilizer at all. And in the unstable hip where other things have failed, be they the bone, the labrum, the capsule, then the ligamentum becomes a secondary stabilizer in that pathological situation. And then if it is charged with stabilizing the hip for long enough, it starts to tear itself, and then they've lost their last stabilizer. So it seems that there may be a role for ligamentum teres reconstruction. And for there to be a role, there has to be a technique. And again, we don't want technique to beget indications, but you can't have indications without a technique. So we developed the technique for ligamentum teres reconstruction, which looks a lot like an all-inside ACL reconstruction. Initially, we did this with a large bore hole through the quadrilateral plate. A little bit scary because the obturator vessels are on the other side, of course, so we have to know where they are. And we used an endo button for the first versions of it, then converted to a smaller button, and then 2 anchors, which I'll show you. We've done the targeting with dual plane fluoroscopy, and we've also more recently done it with the AVN guide that Arthrix had at their booth out there, which makes for a nice guide, almost like an ACL guide to target the drill hole. So we make a tunnel. We actually can use that tunnel as a portal and use that to clear off the very base of the cotyloid fossa and do a decortication in order to create a bleeding bed of bone, because we need biology if we want healing. Here's the graft. This is a doubled over tibialis posterior graft. This was the second generation of the technique where we used a smaller button with a keyhole. And then for the current technique, we use the knotless fiber tack anchors. And here in this video, you can see that button going through a very small hole. And this is a tension slide technique to approximate the graft to that spot. This is with dual anchors. So these are the knotless tensionable anchors. One anteriorly, one posteriorly, both right above the TAL, so at the very base of the cotyloid fossa. And this creates a knotless triangular construct. So we have 2 points of fixation at the base of the acetabulum. And then once we've docked the graft into the tunnel in the femur, we have essentially a double bundle ligamentum teres reconstruction. So it looks sort of like a triangle. In terms of outcomes, we have reported on the 2-year outcomes and found meaningful improvement in the patient-reported outcomes and pain reduction, as well as patient satisfaction. And we have specifically done, that first one was on Ehlers-Danlos patients with a sub-analysis, and the Ehlers-Danlos patients were more difficult, no question. The second study there is a systematic review in which we found that LTU is supported predominantly for patients experiencing refractory instability after previous hip preservation procedures, and pretty much remained our indication. It has remained very, 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 very stringent in terms of our indications, but if I'm looking into the future and speculating, I think there may be an expanding role for ligamentum teres reconstruction in the future, so something to keep our eyes on. PAO is not a career-ending procedure for an athlete. To the contrary, it can be a career-extending procedure for some of them. And a quote from this study, most athletic patients undergoing PAO are female and show postoperative improvements in function and return to athletic play. So in conclusion, this isn't entirely across gender lines, but it's a lot across gender lines. This is more of an issue in females. There's clearly some overlap. The instability is associated with a combination of factors that can include ligamentous laxity, increased femoral eversion, acetabular dysplasia, and the activities themselves, such as dance or gymnastics, that may involve supraphysiologic range of motion. Hip instability is probably always multifactorial, and it's important to understand all the contributors and to have a number of tools in our toolbox surgically to restore stability, including labral repair and reconstruction, capsular plication, ligamentum teres reconstruction, and PAO. Thank you.